Hello, I'm very pleased to announce that we have reached the last lecture on radiology. Actually, I plan to hold 2 or 3 lectures on this topic, but there is not much time left until the end of the semester, so I will have to hurry. So today we will observe different aspects of radiation therapy, definition of the concept, mechanism of biological interaction with living objects, application technologies. Radiation therapy, also radiotherapy or radiation oncology, is the medical use of ionizing radiation as a part of cancer treatment to control malignant cells. It should not be confused with radiology, the use of radiation in medical imaging and diagnosis. The availability of radiation therapy to the world's population varies. North America and Western Europe are able to provide radiation treatment to 120 people on single machine, 20,000 people on single machine. In Eastern Europe, Russia, China, Latin America, one apparatus is designed to provide care from 500,000 to 1 million people. In the rest of the world, up to the 5 million people are served on one machine. The first patient was treated with radiation in 1896, just 2 months after discovery of Wilhelm Conrad Röntgen. The field of radiation therapy began to grow from the beginning of the 20th century, largely due to the groundbreaking work of Nobel Prize-winning scientist Marie Curie, who discovered the radioactive elements polonium and radium in 1898. This began a new era in medical treatment and research. Through the 1920s, the hazards of radiation exposure were not understood and little protection was used. Radium was believed to have wide curative powers, and radiotherapy was applied to many diseases, not only malignant. Prior to Second World War, the only practical sources of radiation for radiotherapy were radium, its emanation radon gas, and the X-ray tube. External beam radiotherapy began at the turn of the century with relatively low voltage X-ray machines. It was found that while superficial tumors could be treated with low voltage X-ray less than 150 kilovolts, more penetrating higher energy beams are required to reach tumors inside the body, requiring high voltages. Ortho voltages X-ray, which used tubes voltages of 200-500 kilovolts, began to be used during the 1920s to treat tumors lying at the depth of a few centimeters. But to reach the most deeply lying tumors, rays with energies of 1 megavolt or above, called megavolt radiation, were required. The invention of the nuclear reactor during Second World War made possible the production of artificial radioisotopes for radiotherapy. Cobalt therapy machines using megavolt gamma rays emitted by cobalt-60 made a revolution in the field of radiotherapy between 1950s and early 1980s. Cobalt machines were relatively cheap and simple to use, also due to its 5-year half-life. The cobalt had to be replaced about every 5 years. Medical linear particle accelerators developed since the 1940s began replacing X-ray and cobalt units in the 1980s, and these old therapies are now declining. Linear accelerators compared with cobalt machines can produce higher energies, have more collimated beams, and do not produce radioactive waste with its attendant disposal problems like radioisotope therapies. The World Health Organization analyzing global cancer trends predicts an increase in number of patients in the whole world by 2030 up to 23 million people annually. Uh, Radiation oncology teams consist of different specialists. First of all, it's radiation oncologist. It's the doctor who oversees the radiation therapy treatment. Medical radiation physicist ensures that complex treatment plans are properly tailored for each patient. Dosimetrist works with the radiation oncologist and medical physicist to calculate the proper dose of radiation given to the tumor and to control this dose. Radiation therapist administers the daily radiation under the doctor's prescription and supervision. And at last, radiation oncology nurse cares for the patient and family by providing education, emotional support, and tips for managing side effects. Here, cancer incidents by sex and size are presented. Different types of cancer for men and women. This is the frequency in the United States, but the proportion between different types of cancer in other countries is the same. As you can see, men most often suffer from prostate cancer and women from breast cancer. Lung cancer is second and colorectal cancer is the third most common malignancy among both sexes. With regard to mortality, lung cancer as a cause of death occupies the first position in both men and women. Today, over 75 cancer patients undergo radiotherapy as a primary treatment due to recurrent disease or with palliation purposes. Radiotherapy goals may be radical or achieving complete tumor regression and complete cure the patient, palliative inhibition of tumor growth and extending of patient life, and at last, symptomatic approach or elimination of the most dramatic manifestations of the disease, pain, compression syndrome, lymphostasis, and so on. Total doses for different kinds of radiotherapy. The radiation doses required to achieve therapeutic effect depend on the goal of prescribed treatment. For the radical elimination of cancer cells and control the tumor, it's usually necessary to deliver 65-75 grays to the primary focus and 45-50 grays to the areas of regional lymph drainage. For palliative or partial or temporary control of the tumor, a dose about 45-50 grays is usually sufficient. If there is no hope of even a partial tumor response, doses up to 30 grays are used to discontinuate the most severe symptoms. This improves the quality of life for several weeks or months in patients whose expectancy of life is very short. Radiotherapy is used for the treatment of malignant tumors or cancers and may be used as a primary therapy. It is also common to combine radiotherapy with surgery, chemotherapy, hormone therapy, or some mixture of the three. Most common cancer types can be treated with radiotherapy in some way. The precise treatment intent, it may be curative, adjuvant, neoadjuvant, therapeutic, or palliative, will depend on the tumor type, its location, stage, as well as the general health of the patient. Combination of radiotherapy and surgery may be provided as additional or adjuvant treatment after complete removal of malignant tumor. Its goal to destroy the remaining cells and prevent relapse. Also as additional treatment after partial removal of the tumor when complete removal is impossible. A goal in this case is to try to destroy the remainder of the tumor and stop its growth. In the treatment of unresectable tumors, purpose to slow or stop tumor growth, possibly transfer tumor into resectable stage. And at last, neoadjuvant approach is done before surgery to achieve better local control because residual cells in tumor bed after surgery lose vitality after irradiation and cannot divide. What is radiation therapy? Radiation therapy works by damaging the DNA within cancer cells and destroying their ability to reproduce. When the damaged cancer cells are destroyed by radiation, the body naturally eliminates them. Normal cells can be affected by radiation, but they are able to repair themselves. Sometimes radiation therapy is the only treatment a patient needs, but in most cases it is combined with other treatments like surgery and chemotherapy. Mechanisms of radiation cytotoxic effects. There are two main mechanisms. So-called interphase death or apoptosis is not associated with division of cells, occurs in the first hours after radiation due to direct and irreversible damage to membranes and organelles. And another mechanism or reproductive death is loss of reproductive ability, occurs at the time of the next cell division after radiation due to radiation-induced DNA damage and loss of genetic information. Both these mechanisms may be present as in tumor cells as in normal tissues. And so the task of sparing of normal tissue and prevention of its radiation damage is very essential. There are direct and indirect mechanisms of interaction between radiation and living objects. The direct effects consist in single or double-strand DNA bricks as a result of absorption of radiation energy by this molecule. In this case, double-strand bricks lead to immediate cell death and are therefore called lethal. Single-strand bricks can be repaired by cross-linking DNA by cell enzyme systems. After that, the cell doesn't die immediately and can even enter the next mitosis. However, dotted cells are no longer viable due to damage of the hereditary apparatus. Thus, after the implementation of the indirect effect, the tumor must remain the same for some time, and only with onset of the next mitosis begins to decrease. From a practical point of view, this is important in that we should not expect the effect of radiation earlier the completion of radiotherapy. Most of the damage to DNA molecules from X-ray is accomplished through the indirect effect. When X-ray or gamma ray enter at cells, they are much more likely to hit a water molecule because there are a large number of water molecules in each cell. When the X-ray ionizes the water molecule, ions and free radicals are produced, which in turn bond with a DNA molecule, changing its structure. Since the X-ray interacted with the water molecule before the DNA was involved, this is considered as indirect effect. Indirect ionization occurs when non-charged particles, for example photons, interact with cellular water and cause its radiolysis. The energy absorbed by water molecule results in the formation of ion pairs and reactive oxygen metabolites such as hydroxyl radicals. In turn, these free radicals interact with cellular atoms and molecules, damaging cellular proteins and may form additional free radicals. The process is known as indirect because the intermediate step of water-based free radical formation. The effect of radiation therapy depends on the radiation dose delivered to the tumor. It's the main rule in modern radiotherapy. Organs at risk, it's normal tissue which radiosensitivity may significantly affect the treatment planning and or prescribed dose. Ideology of modern radiotherapy is to achieve optimal balance between maximum tumor suppression and avoiding of potential adverse events from normal cells. Principles of radiotherapy are providing precise uniform irradiation of all tumor cells, prevention of exposure of healthy tissue surrounding the tumor and adjacent organs above their tolerance, and measures stimulating protective forces of the body. The therapeutic use of ionizing radiation is based on its biological action. That's its ability to cause changes in cells, tissues, organs, the body as a whole. It depends on the absorbed dose, energy transmitted to irradiated tissues. This dose is measured in grays. Radiosensitivity of healthy and tumor cells are practically the same. And here is very important the concept of so-called radiotherapeutic interval. This is a difference between radiosensitivity of the tumor and surrounding healthy organs and tissues. It should be increased as much as possible because the wider is the corridor between the probability of tumor cells death and probability of normal cells killing, the more effective will be control over the tumor and at the same time lower risk of radiation damage. As you can see, when a dose of 60 grays is applied, its radical dose for most tumors, In the case of high radiosensitivity of tumor, up to 90% of malignant cells are suppressed, while the reaction from normal cells has not yet occurred. On the contrary, in the case of tumor radioresistance, up to 60% of normal cells are damaged at the same dose of 60 grays, while tumor cells remain intact. In other words, the survival curves of malignant and normal cells change their position. Radiotherapy treatment planning operates with such terms as gross, clinical, and planning target volume. Gross target volume is macroscopic tumor volume, palpable or visible on CT or MRI, visible extent of malignant growth. Clinical target volume contains gross target volume and potential subclinical microscopic malignant spread, which has to be eliminated. Commonly, it's GTV plus 1 centimeter. And planning target volume is volume to account for daily setup uncertainties, organ motions in such organs as stomach or breathing. This is a geometric concept is defined to be sure that the prescribed dose is really absorbed in CTV. The highest concentration of tumor cells is observed in a gross target volume. However, when planning the irradiation, we should not be limited only to this volume, since malignant cells in the area of subclinical dissemination or in clinical target volume invisible on CT and MRI can be a source of further tumor progression. Therefore, the planned target volume should be greater than the clinical one. According to modern requirements, the error of the prescribed dose in relation to the actually absorbed dose should not exceed plus minus 5% in magnitude and plus minus 3% in space. There are different types of radiation may be used for radiotherapy. Photons or X-ray or gamma rays, electrons, beta particles, and heavy particles, protons or neutrons. These sources differ primarily in the radiation power, therefore in their penetrating ability. Sources of radiotherapy. A. Therapeutic X-ray machines or X-rays. Gamma therapeutic machines equipped with cobalt-60 isotope. Linear accelerators, which produces electrons or photons beams. Cyclotrons or accelerators of particles of electrons or protons. Also nuclear reactors, which operate with also with particles with neutrons, and at last radionuclides such as iodine, strontium, and many others. Radiation therapy can be delivered in two ways, externally and internally. External beam radiation therapy delivers radiation using a linear accelerator, and internal radiation therapy, called also brachytherapy or seed implants, involves placing radioactive sources inside the patient. The type of treatment used will depend on the location, size, and type of cancer. Please have a quick look at the loaf of bread and imagine that you ate it right away. You will not feel well, won't you? But if you divide the whole loaf on several portions and eat them day by day, you will be fine. The same story is with radiation. The total dose is fractionated or spread out over time for several important reasons. Fractionation allows normal cells time to recover, while tumor cells are generally less efficient in repair between fractions. Fractionation also allows tumor cells that were in a relatively radioresistant phase of cell cycle during one treatment to go into a sensitive phase of the cycle before the next fraction is given. Similarly, tumor cells that were chronically or uh, acutely hypoxic and therefore more radioresistant may reoxygenate between fractions, improving their cell kill. The new International System Unit of Radiation Dose expressed as absorbed energy per unit mass of tissue. Unit dose in radiotherapy is gray, or 1 gray is equal to 1 joule per kilogram of substance. Gray can be used for any type of radiation, alpha, beta, neutron, gamma, but it doesn't describe the biological effects of different radiations. From a purely physical point of view, 1 gray is the amount of energy sufficient to raise the temperature of a glass of water by 1 degree Celsius. You will not feel or notice such small amount of energy. However, radiation has an effect on biological objects, not by heating them, but by damaging vital cellular structures, primarily DNA. Historically, the three main divisions of radiotherapy and external beam radiotherapy, brachytherapy or sealed sources radiotherapy, and systemic radioisotope therapy or unsealed source radiotherapy. The differences relate to the position of radiation source. External is outside the body. Brachytherapy uses sealed radioactive sources placed precisely in the area under treatment, and systemic radioisotopes are given by infusion or oral ingestion. Brachytherapy can use temporary or permanent placement of radioactive sources. Different types of apparatus you may meet in your practice as radiation oncologist. They are X-ray machines, cobalt machines, photons, therapy by photons of linear accelerator, therapy by electrons of linear accelerator, brachytherapy by the closed radionuclides, and brachytherapy by grains of radionuclides. Different radiotherapy machines generate radiation beams of different energies. In practice, this means different penetrating power of different beams. Let's compare, as an example, the energy absorption or curves for cobalt, black curve, and for 8 megaelectron volt linear accelerator, green color. In both cases, we are talking about gamma rays, photons. As you can see, for cobalt machine, only about 40% of the dose prescribed for one fraction will be delivered to a depth of 15 centimeters. The remaining 60% will be absorbed in healthy tissues that lie in the path of the beam to the target volume or to the tumor itself. As a result, we will observe under-irradiation of the tumor and over-irradiation of organs at risk. The 8 megaelectron volt photons of linear accelerators, as more powerful, can penetrate into tissues deeper and with less energy loss in surface tissues. So, at the same depth of 15 centimeters, these rays will lose about 40% of their initial energy and 60% of energy will be absorbed in the tumor. Thus, the ratio between the part of energy absorbed in the tumor and normal tissues is preferable for linear accelerator. Electrons with an energy of 20 megaelectron volts, red curve, are almost completely absorbed at depths of 5 up to 7 centimeters, then their energy decreases rapidly. Such dose distribution is preferable for shallow superficial tumors when it's necessary to avoid undesirable irradiation of underlying tissues. Finally, the best dose distribution is demonstrated by high-energy particles, protons and neutrons, blue curve, which pass through the surface layers with very little energy loss and leave almost all energy at a given depth. In this example, 25 centimeters. Tissues lying in the path of the beam in front of the tumor and behind it are practically not irradiated. In practice, unfortunately, the use of particles in medical practice is associated with great technical difficulties. Therefore, preference is currently given to accelerators. Let's have a quick look at the practical application of different radiation therapy machines. X-ray therapy is most effective for superficial lesions such as skin cancers and some non-cancerous skin conditions, including non-melanoma skin cancers arising from the outer layers of skin, basal and squamous cell carcinoma, Kaposi's sarcoma, and keloid scars. X-ray therapy may be realized as so-called short and long focus technique. Short focus means irradiation at skin focus distance of 3-5 centimeters and voltage generating in X-ray tube 30-60 kilovolts. And long focus or orthovolt irradiation is done at skin focus distance of 30 centimeters up to 1 meter and voltage generated in X-ray tube 180 up to 250 kilovolts. In the design of a linear accelerator, it's necessary to distinguish 3 main elements. A gantry in which free electrons moving at a speed of light reach they exit from the apparatus, where they are either formed into a beam of electrons or collide with a solid anode, resulting in a beam of photons. Either electrons or photons enter the second most part of the accelerator, so-called multi-leaf collimator, which converts electrons or photons into a uniform and parallel beam. In collimator, the shape of a resulting beam of rays is adjusted to the parameters of the tumor focus, which ensures its accurate irradiation. This is achieved using a variety of thin plates that can move independently of each other and form a field of any geometric shape. The treatment couch on which the patient is placed moves him under the beam so that the beam of electrons or photons completely covers the selected volume of irradiation. In some radiotherapy centers, a diagnostic CT scanner and a linear accelerator are mounted in the same room. Then it's possible to obtain diagnostic images of the tumor in a very short time and irradiate it without removing the patient from the treatment couch. The treatment couch has 4 degrees of freedom in its movement, which maximally facilitates the correct positioning of the patient under the beam. Linear accelerators give possibility of exposure of tumor to either electrons, either photons of high energy. Immobilization is the next step in treatment planning. It's the use of the fixture, allowing the patient to prevent displacement of the target position, as between sessions of irradiation as in a signal fraction. Simulator is an X-ray diagnostic machine that exactly repeats all the parameters and design features of linear accelerators. It also matches the patient position on the treatment couch with the linear accelerators data. All the necessary measurements calculated during the planning of the irradiation process are transferred using the simulator to the patient before the first therapy session. First of all, it is the exact position of the patient's body, the angle of direction of the beam, the boundaries of irradiated touches. All this data is stored in the digital X-ray machine. All other units are used for concentration of therapeutic beam at either center of irradiation field and allows us to ensure that patient is placed correctly on the treatment couch. Different steps of external beam radiotherapy planning are presented here. First of all, it's delineation of the target. Then next step, selecting of source. You may prefer cobalt machine or linear accelerator. It depends. Next step is selecting of fields. In other words, choosing of gantry angles and beam directions. And at last, selecting of fractionation regime. Either those curves, its lines connecting all points with the same value of the absorbed dose. Taking the maximum value of the absorbed dose for 100%, planning system creates isodose curves, respectively 90, 80, 70, 60 percent, and so on, connecting the corresponding values in the cross sections. According to modern requirements, the primary tumor and areas of regional lymph outflow should be covered with at least 95 isodose, and the organs of risk should receive no more than 50% of the tumor dose. Three-dimensional planning is based on the summation of cross-scan MRI, CT, PET-CT, and gives the possibility of obtaining three-dimensional image of the tumor and healthy tissue. Three-dimensional radiotherapy is a cancer treatment that shapes the radiation beams to match the shape of the tumor. The radiologist determines for each CT slice the area of tumor, the area of subclinical tumor dissemination, critical organs, prescribes the dose that is necessary to be delivered to each area. Here is the example of treatment planning for tumor of right parietal lobe of brain. The next step is the selection of exposure or dose distribution planning with the help of special computer programs of 3- and 4-dimensional planning. Now let's talk about different techniques of external beam radiotherapy. Conventional X-ray, conventional external beam radiotherapy. In two-dimensional planning, it is assumed that the tumor has cylindrical geometry, or in all sections it has approximately the same shape than in central section. With this approach, it's enough to choose the width of the rectangular irradiation field in the section passing through the middle of the tumor and determine its length depending on the position of the upper and lower pole of the tumor. Conventional external beam radiotherapy is based on this three-dimensional approach, uses irradiation fields of a rectangular or square shape, resulting in the inevitable and undesirable exposure of normal tissues to irradiation. Conformal external beam radiotherapy is next step in radiotherapy techniques. The principle is to create the optimal shape of radiation beam exactly corresponding to the shape of tumor using multi-leaf collimator. Modern collimators are equipped with 80 or even 180 leaves, which of these leaves can move independently and allow to create radiation field of irregular geometry. Further development of conformal technology is intensity modulated radiotherapy. When leaves of the collimator during a session do not remain fixed but change their position, thus constantly adjusting for the shape of radiation field to the shape of tumor. Due to moving of collimator's leaf, the radiation dose varies over the exposure time, depending on the thickness of the target or the thickness of tumor. In that position of gantry, where the target thickness is more than the beam can pass, the intensity of irradiation increases. Where the target thickness is reduced, the beam power is also reduced. Intensity modulated radiotherapy makes it possible to form an irradiation field, part of which has a concave shape. Conformal and intensity modulated therapy and their comparison. Comparison of conformal radiation with intensity modulating techniques on the example of oropharyngeal cancer allows us to make sure that with IMRT the dose of 64 grays prescribed for the planned target volume is shown in black. This dose of 66 grays is absorbed only in this volume, whereas with conformal radiation therapy, the same high dose is received also by healthy neck tissues, including on the opposite healthy side. Rapid arc radiation therapy is a technique that combines intensely modulated irradiation with rotational arc delivery of the linear accelerator. The treatment consists of 360-degree rotation of gantry with the beam focused on the target. These techniques utilize a higher number of degrees of freedom to achieve desired dose distribution. First of all, the beam is on during whole cycle of gantry rotation, and at the same time, gantry speed, leaf position, leaf speed, and dose rate or power of the beam may be varied. Comparison of intensity modulated irradiation with rapid act using the example of oropharyngeal cancer allows us to make sure that the dose in the planned target volume red area is the same, while with rapid arc the dose is lower for adjacent neck tissues, especially on the opposite healthy side. Image-guided radiotherapy is a further development of precision irradiation techniques and focuses on time-varying change of position of tumor and normal tissues. Sometimes its plan is not quite true called four-dimensional, meaning time as the fourth dimension. The gist of it is that with the help of various devices, sensors, volume, laser centrators, radiographs obtained in real time, target is irradiated only at times when it is located strictly in the radiation field. This helps significantly reduce the amount of radiation exposure of normal tissues. Image-guided radiation therapy is a linear accelerator equipped with optical recorders of the chest and abdominal wall movement during breathing, yellow arrows. The respiratory motions of the sensors placed on the patient's body causes a change in the position of the gantry and the direction of the beam, preventing the tumor escaping from the treatment beam in different phases of respiration. Let's summarize the different differences between all irradiation technologies we have just covered. These differences will consist in what happens during a treatment session with the main units of the linear accelerator, with the gantry, multi-leaf collimator, and radiation beam. With conventional irradiation, as a rule, opposite fields are used without a collimator. Equip your apparatus with a collimator and you will receive conformal irradiation. Make the collimator leaves move not only when changing from one field to another, but also during a treatment session, and you will receive an intensity modulated irradiation. Use not only fixed angles for irradiation, but force the gantry, make a full rotation around your patient, at the same time varying the beam power, and you have advanced to rapid arc technology. Provide the ability to control changes in the position of the target during breathing, and you have image-guided radiotherapy technology at your disposal. Contraindications for radiotherapy also should not be forgotten. They are, first of all, poor performance status of the patient, cachexia, hematological disorders such as anemia and leukopenia, acute sepsis, decompensated states of heart, liver, kidneys, and other organs, active tuberculosis, tumor invasion into gray blood vessels because it increases risks of uh, life-threatening bleeding, and paraneoplastic inflammatory process because formation of abscess is also may happen. Indications for radiotherapy. Predominantly, radiotherapy is used in cancer treatment and only in a few percent of cases for benign disease. Some words about total dose and fractionation. The amount of radiation used in radiation therapy is measured in gray. Sorry. And varies depending on the type and stage of cancer being treated. For curative cases, the typical dose for solid epithelial tumor ranges from 60 to 80 grays, while lymphoma tumors are treated successfully with lower doses, about 20 or up to 40 grays. Most often, the total dose is delivered into the so-called classic or conventional fractions. This means 2 grays per fraction, 5 days a week, and the total treatment time is up to 5-7 weeks. To overcome the radioresistance of the tumor or to shorten the treatment time, the size of a single fraction can be increased to 3 and even to 10 grays. However, all enlarged regimens are usually not radical but palliative. Brachytherapy is a kind of radiation therapy which uses sources of relatively low power located directly in the irradiated tissue or at very small distance from it. With brachytherapy, we obtain possibility to deliver maximal doses of irradiation directly to the tumor with minimal impact on the surrounding healthy tissues. Methods of brachytherapy are interstitial, delivered by needles or grains of radioactive isotopes used for prostate cancer, breast cancer, head and neck tumors. And next approach is intracavitary brachytherapy for those organs which have cavities. for cervix, endometrium, vagina, rectum, esophagus, bronchi. Most often, brachytherapy is used not as an independent method, but in combination with external beam radiation therapy. Depending on the power of the source, different times are required to deliver the prescribed dose of radiation. Therefore, high, medium, and low dose brachytherapy are distinguished. From a radiobiological point of view, low dose radiation is preferable because in this case, tumor is exposed to radiation for many hours and even many days. And all tumor cells will sooner or later be irradiated in the mitosis phase, which is most radiosensitive. However, the problems of radiation safety and convenience in practical use, difficulties in practical use, make us now give preference to high-dose brachytherapy. And most clinics in the whole world are equipped with high-dose brachytherapy machines. Intracavitary brachytherapy uses vaginal, uterine, rectal applicators, catheter for bronchi, blood vessels, biliary tract, esophagus, and so on, for all organs which have cavities. Also may be delivered by hollow needles for interstitial tumors. Hollow needles may be solid and flexible. Gamma ray sources are more suitable for high-dose intracavitary brachytherapy. The most commonly used are cobalt and iridium, which have the same emission spectrum. Sources of iridium, due to its short half-life, must be changed every 3-4 months, while the source of cobalt can be effectively used for 5 years. For interstitial brachytherapy, short-lived isotopes that generate gamma or beta radiation are more suitable. Among them, iodine stands out, which, due to its soft spectrum, is indispensable for brachytherapy of prostate cancer and brain tumors. Here, construction of source for brachytherapy is presented. You see that it's a very small thing, not more than 4.5 centimeters in general length, with active source component not more than 3.5 millimeters length, and total diameter only 1 millimeter. Source pitch in the applicator for this source is half a centimeter, and step by step this source of, in our example of cobalt 60, stops in different position and step by step covers all area which should be irradiated. Here is example of interstitial brachytherapy. One of most effective techniques in whole brachytherapy is treatment of early stage prostate cancer. Techniques of iodine 125 seed implantation in the prostate gland under ultrasound control, using ultrasound probe inserted in rectum, template to aid accurate placement of needles in the tissue of prostate, and at last the final position of needles in the patient, and control CT and X-ray control of correctness of inserted needles. After insertion of iodine sources, these sources remains in patient's body for the rest of life. They are not evacuated back. Rest isotopes are taken back from the patient body, from the tumor, from our target volume, taken back into apparatus. Radionuclide therapy or beta therapy used radionuclides that undergo beta decay. Millage of beta particles in the tissues of human body does not exceed 1 centimeter. It gives possibility of exposure only of pathological focus. Procedure is safe to surrounding persons. Millage of beta particles in air is about 1-2 meters, and this arises the problem of radiation protection for personnel during filling and issuing of radiopharmaceuticals. Beta therapy is carried out by introducing colloidal solution radionuclide perose or parenterally that is slowly absorbed and thus provides long-term exposure. Preference is given to high energy radionuclides which emit beta particles and have relatively short half-life, from 2 days to 2 weeks. This creates possibility of almost complete decay of radionuclide during treatment. Beta therapy is indicated first of all for disseminated metastatic lesion of the pleura and peritoneum, bones, and so on. In local lesions, not radiotherapy, not beta therapy, radionuclide therapy with beta particles, but external beam radiotherapy with linear accelerator or cobalt machine is preferable. Examples of isotopes which are in wide use for beta therapy. First of all, it's iodine 131 for ablation of residual thyroid cancer after surgical treatment of thyroid carcinoma. Strontium 89 for treatment of multiple metastases in the skeletal system. Strontium has tropism to bones as a physiological calcium analog. And phosphorus 32 for treatment of erythemia, leukemia. This isotope has tropism to bone marrow, also may be used for bone metastasis, but it accumulates predominantly in the bone marrow and may cause a severe anemia. So for bone metastasis, you should better choose strontium and leave phosphorus for erythemia. There are several factors limiting the radiation dose. It's, first of all, tolerance of normal tissue surrounding the tumor, or in other words, potential radiation reactions or radiation injuries. Radiation reaction or early effects are changes in the tissue that develop up to 3 months after irradiation and regress in next 2 or 4 weeks without any treatment. Radiation damage or late effects is irreversible pathological process developing at a late date after 3 months, 6 months after irradiation and requiring active medical or surgical treatment. Earlier radiation effects may be divided on general and local. General are deterioration in general conditions, increase of body temperature, weakness, dizziness, dysfunction of gastrointestinal tract, loss of appetite, nausea, vomiting, diarrhea, also violation of the cardiovascular system such as tachycardia, chest pain, hematopoietic disorders, anemia, neutropenia, lymphopenia, and others, and local effects which develop strictly in the irradiated area. Reactions from the skin, epidermitis, alopecia, from mucosal folds, oral mucositis, esophagitis, laryngitis, enterocolitis, rectitis, cystitis. So reaction of normal mucosa of irradiated organs. Pneumonitis may develop in lung, and heart damaging will be cause of cardialgia and arrhythmia. Late radiation effects or radiation damages are atrophy and or skin, telangiectasis, fibrosis of subcutaneous fat, radiation ulcer, which develops from 6 months to years from the completion of irradiation, carcinogenesis, even after 10, 15 years after irradiation, we may observe secondary malignancies in previously irradiated areas. Also, stop of bone growth in childhood if bones appears in irradiated fields when child is treated, for example, for lymphoma, this bone further will stop growth. And at last, lymphostasis, especially in areas previously operated. Here is example of severe complication of radiation ulcers which cannot be treated conservatively and needs surgical operation or replacement of ulcer with normal skin. Results before and after treatment, comparison before and after treatment shows us that it's maybe successfully treated. These complications of radiotherapy may be successfully treated with surgery. Non-cancer indication of radiotherapy are listed here. I will maybe not focus on them in very details and say only that efficacy of radiotherapy for benign diseases due to the following radiation effects: anti-inflammatory, analgesia, desensitization, so also anti-spastic effect and anti-secretory effect. Total doses and fractionation differs from doses and fractionation in cancer treatment. You may compare dose, single dose and total dose in acute and chronic phase of different non-cancer process uh, and conclude that total dose in acute phase, dose of 1 gray is less than dose given for cancer only per 1 fraction. And here we use a total dose of 1 grays. Rhythm of irradiation is usually every other day. In practice is most suitable to treat patients on Mondays, Wednesdays and Fridays. In the case of aggravation of the process or appearance of separation, interval between sessions should be increased up to 3 days. Now, practical approach. Does the patient undergoing radiotherapy present danger to other persons? In the case of external beam radiation therapy, the patient receives gamma radiation of high power which does not accumulate in the body. The patient doesn't become radioactive and causes no danger to others. Brachytherapy uses gamma radiation of low power intended to act only in the site of application. The patient is isolated from the others only for the period of sources application, and after removal of radioactive sources is not radioactive, and is not dangerous to people around him. In cases of radionuclide radiation therapy uses open radioactive substances that circulate throughout the body, I mean beta emitters in blood flow. A certain part of an administered substance can be released through saliva, sweat, and urine. Therefore, people who are in close contact with the patient must comply with certain protection. But we should remember that dangerous distance between person who undergo radionuclide therapy and intact person is several centimeters, and distance more than some centimeters is quite safe. World Health Organization made the following conclusion: that success of radiotherapy depend on 50% on the radiosensitivity of tumor and 25% on equipment, cobalt machine, linear accelerators, or most old techniques, and 25% due to treatment planning. Here, all reasons which may affect on efficacy of your radiotherapy. To learn more about radiation therapy, you will have possibility if go to these links. I'll just come back to this picture and copy these links. I understand perfectly well those who are extremely tired of my lecture, and I propose to relax looking at this playful picture. If you have a career as a radiation oncologist in your mind, you should definitely need such a t-shirt. I thank you for your attention, not only today, but also to all the previous lectures. I have seen dozens and hundreds of your visits to the information platform of our department. This is really very pleasant. I hope the lectures were not useless. I am sure that all of you will successfully pass the final test. My best wishes to you in everything, and goodbye.